Good afternoon, everyone, and welcome to the SAMHSA-HRSA Center for Integrated Health Solutions webcast titled Critical Skills for Activating Self-Management. My name is Rose Felipe, and along with my colleague Larry Fricks will be your moderator for today's webinar. As you may know, the SAMHSA-HRSA Center for Integrated Health Solutions promotes the development of integrated primary and behavioral health services to better address the needs of individuals with mental health and substance use conditions, whether seen in specialty behavioral health or primary care provider settings. In addition to national webinars designed to help providers integrate care, the Center is continually posting practical tools and resources to the CIHS website, providing direct phone consultation to providers and stakeholder groups, and directly working with SAMHSA primary and behavioral healthcare integration grantees and HRSA-funded health centers. Before we get started, I'd like to go over a couple of housekeeping items. To download the presentation slides and supplemental resources, please click on the drop-down menu labeled Event Resources on the bottom left of your screen. Slides are also available on the CIHS website located under the tab About Us and under Webinars. During today's presentation, your slides will automatically be synchronized with the audio, so you will not need to flip through any slides to follow along. The audio will come from your computer speakers, so please ensure those are on and the volume is up. To submit questions to the speakers at any time during the presentation, you can type into the Ask a Question box located in the lower left portion of your player. Finally, if you need technical assistance, please click on the question mark button in the upper right corner of your player to see a list of frequently asked questions and contact information for tech support. And now I'd like to turn things over to Larry Fricks.
Thanks, Rose, and thanks for everyone joining us today. Our purpose today is helping individuals identify their personal motivation and goals vital to the success of primary and behavioral health integration. After this webinar, participants will understand the importance of tapping into individual strengths and motivation to set person-centered health goals, recognize the key skills needed to support activation of self-management, and gain lessons learned, resources, and references for additional information on activation of self-management. And activating self-management is so important for both primary care and behavioral health, showing outcomes of efficacy and cost savings. And our presenters today will share more about that. Our first presenter is Sue Bergeson, who is Vice President, Consumer and Family Affairs for Optum Behavioral Health. And we also have Harvey Rosenthal, who's Executive Director, New York Association of Psychiatric Rehabilitation Services. And then Tanya, Director of Peer Services, New York Association of Psychiatric Rehabilitation Services. So Sue, take it away.
Sue? Thank you. I seem to have been on mute, but I had a great start, guys, so I'm just saying, cannot repeat that start. It was so good. All right, let me try again. So I am a person with a lived experience. Everyone in my family lives with a behavioral health and physical health condition. My sister died by suicide. Before I came to Optum Behavioral Health, which is a large managed care company, I was the CEO of the Depression and Bipolar Support Alliance. I focus a lot right now at Optum with the issues of activation and self-care. And next slide, please. What I want to talk about today in 20 minutes, very briefly, is let's talk a little bit about the research around this issue, give you a couple resources you can probe into and just really explore in your own time. Let's look at activation through the lens of a couple different theories out there, again, very briefly, so that you can kind of say, all right, I need to know a little bit more about that or about that, and do that on your own time. 20 minutes is a lot of time here, so I'm going to jump through that. I'm going to be very specific about some practical things you can do in whatever environment you're in. to support and promote activation, and I'm going to give you a few clues about activation tools that are out there that have met some really great gold standards. Next slide, please. So this is me, and there I am on the right-hand side. It's just my normal whatever. And there I am in the middle, and as you can guess, this is about my second round of chemotherapy. I was diagnosed with breast cancer on one day, and the next day I was diagnosed with uterine cancer, completely unrelated, and went through lots of surgeries, lots of chemo, lots of radiation, and there I am. I still have my eyebrows, so I'm thinking I probably was at my second chemo. I don't know. And there I am at the left-hand side. It's a hard picture for me to look at. Super cute. There's my dog Cassiopeia, and she's got her dog goggles on. We used to put the top off on the Jeep and run around, so she has to have her goggles on. But in that picture, I know I was very ill. I was trying very hard to stay alive. I was deeply, deeply depressed, so it's hard for me to look at that. But what's interesting to me is you can see the quote at the bottom that I pulled. Most people are more afraid of living with cancer than just about anything. But I have to tell you, in my experience, living with a behavioral health condition was much, much, much harder. And then, there I am doing my chemo, and as I'm progressing down the road with chemo, and, I've got more and more and more of that going on, and thank goodness, but it's eroding the self-protection that I have in place to manage my ongoing depression. So not only now am I coping with the illness, but I'm also coping with the behavioral health illness, because chemo doesn't just destroy, the tissues. It also destroys lots of other things in your body. So what's interesting about this is that I used the same self-care and activation tools for the beginning of my cancer journey, for my behavioral health journey, and for my combination behavioral health and physical health journey. I used them at different intensities. I added some, I took some away, but the same processes were in place for all of that. Next slide, please. So when we're talking about engagement and activation, what are we really saying? A lot of times we use the words as if they are the same thing. Engagement means activation means engagement, and it's not really. I think we do better if we think about these as parts of a continuum. So I'm engaged when I go see my doctor. And when I say I mean kind of the larger I, the patient. And that's a good thing. And that's not simple, right? A lot of people have a lot of barriers to that kind of engagement. But if I'm not activated, then we have a whole series of other problems. And I bet every single person listening in today has been engaged in going to see their doctor, but not activated with what they've said you probably should do. Like anybody, been told they need to lose 5 or 10 pounds, or they need to stop smoking, or my favorite was, Sue, it's time for you to get regular colonoscopies. I'm like, yeah, really? So it took me a little bit of time to get activated in actually doing that. So there's a disconnect between engagement and activation. Now, probably the best researcher out there in this area is Judith Hibbert. And I encourage you to go online and read her work. And she said really there are 6 things that are core to really involving people and activating them in their own treatment. And as I go through these, you should be thinking, how are we doing that? How can we add that? How are we intentional about that? It's not checking off a list. It's thinking about your processes to say, how do we do it? How can we enhance this? And the first one on this list really is symptom self-management. So are you putting symptom self-care tools in people's hands? Are you giving them, a series of tips and tricks that they can be using when some of those symptoms get overwhelming, and they may be behavioral health symptoms, or they might be other symptoms they're feeling like pain or other things? What are you doing to give them things they can do so that those symptoms don't escalate and they don't end up in the ER? What are you doing to help engage people in actions that support health and functioning maintenance? I don't know about you, but I have always known that I should be exercising quite a bit every day, all those things, but I wasn't quite ready to do that. So there is an issue here with readiness for change that you have to think about when you're helping people engage in actions that support health, not just get rid of illness. And then the third thing is involving people in treatment decision-making. And this is not just saying, do you want this medication or that medication? Would you prefer this surgery or that surgery? If I don't have enough information, I can't make a good choice there anyway. And so part of the art of this is really understanding who the person is that you're interacting with on a much deeper level than we might be doing right now. For example, did you know that most of us in the provider system will listen to the consumer or the patient for about 8 to 11 seconds before interrupting? And you know, that really means we're passionate, we have an idea, we want to help these people. But if you haven't listened to me and really understand my life, then I'm not really going to trust you, and we're not involved in a collaboration. And then, of course, 5 is critical performance-based. Well, number 4 is collaboration with healthcare providers. So we talked about involvement in treatment decision, but we also have to collaborate differently. I know some things as a patient that are really important, and you probably need to understand them. And you know some things, and thank God you do, as a provider of care, but together we make a whole. And the problem is, if we treat everyone like their disease and don't understand that the nuances of their particular iteration of that illness, then we're not in a collaborative relationship. We also need to support people in making good choices around providers, and if it's not working, to have the freedom to say, I need to choose someone else that I can communicate better with, and not penalize people for saying, hey, this is not working for me. And then helping people navigate the provider system. I gave you my example of the cancer. At one point, I had 28 different people who were critically involved in my care, and I had to track them and figure out what they needed and all these things, and it was completely overwhelming. We do not have simple systems of care, so this is a pretty important piece. And then Judith adds a little throwaway at the end, which is not a throwaway at all. And she reminds people that, you know, you also have to think about patients' beliefs, and that really speaks to culture. You have to know that people have some knowledge and some skill to do these things, and they have to have emotional support to get it done as well. Next slide, please. So, you know, this is just summarizing. I'm engaged when I go see the doctor. I'm activated when I actually do the work too, and you can fill in the blank for yourself. And the cartoon reminds us that people are engaged in different levels around different things at different times. This is not a box check off. This is an art form that you're managing to help people become activated in a range of care. Next slide, please. Okay, so you always want to feel good that what we're talking about really has some research behind it. And I'm just going to run through this, and I encourage you to really look at this more carefully on your own time. But here's some research that shows that being engaged and active is linked to better health outcomes. Training people with chronic disease to self-manage has better outcomes. And by the way, this is the second quote down, and Kate Lord talks about this being a short term, but you know, the results on her work show that 5 years after taking her chronic disease self-management program, people are still benefiting from that. So, you know, 5 years is not short-term in my world, but it might be in another world. And then we see research has a positive relationship between self-efficacy, prevention, and outcomes. Then we see collaborating on care, better outcomes, coaching people, better outcomes. Next slide, please. And then we have some research that say, hey, if people aren't able to navigate the system, we have worse outcomes. And if people do choose great doctors, they have better outcomes. So in summary, people who are able to self-manage their symptoms, people are engaged in activities that maintain functioning and reduce health decline, people are involved in treatment, collaborate with providers, select providers based on quality, and navigate the system, are likely to have better outcomes. Next slide, please. So how do we do this, really? And you can see the cartoon on the slide, and there we are. This woman is throwing the ball to her dog. Go fetch the ball. And they're looking off in the distance and at the ball, and the dog is looking, and she's saying to the dog, how come you don't fetch the ball? And the dog is saying, how come you didn't throw a squirrel, right? And that is my whole presentation. I could stop right now. So the art of activation really is first built on trust. Remember, they'll talk to me more than 8 to 11 seconds. It starts with my strengths. Let's talk about what I do really well and where I want to go instead of what's wrong with me and how sick I am. Well, it's based on stages of recovery, and we're going to look at that in a minute. It's in sync with my own goals. Maybe what I really want in my life is to keep working at Pizza Hut. And my diabetes and my medication for my depression mean I don't wake up on time and that I can be a little bit irritable sometimes. So everything should be framed around my desire to work at Pizza Hut because I want the money and I want the collaboration with my friends and such. And that has to be the way we frame treatment so that people actually are engaged in their own self-care. It makes sense to them. And then we want to explore the best self-care tools, and really you want to curate the right one for the person at the right time based on their level of change and based on their stage of recovery. Next slide, please. We'll talk about stage of recovery in a minute. So stages of change theory. If you haven't interacted with the TTM model with Prochaska and DiClemente, I really encourage you to, jump into that a little bit. It's easy to find that information. And it says that people move through change in stages that are predictable. So whether I'm going through a divorce, I'm stopping smoking, I'm dealing with a mental health condition, I'm dealing with diabetes or heart disease, I'm going through a series of change stages that are predictable. I might be in it for a week. You might be in that stage for 10 days. You might be in that stage for 6 months. I might be in the next stage for a year. The time in the stages can vary, but the stages themselves are predictable. And Larry Fricks, who should be doing this presentation because he's so amazing and awesome, has layered on top of the stages of change kind of a recovery model. Next slide, please. And here you can see it. And so the stage 1 impacted the illness. We're completely overwhelmed. What we need here is to deal with the symptoms. So if I'm there, if I'm completely overwhelmed, you're probably not going to hand me a bunch of self-care and activation tools. You're going to make a decision based on that stage of change that what might be helpful is me watching a short video of a consumer who says, I've been there too, I can do it. Or maybe like my dad, you have a consumer come in and say, I've been through this same heart process, and I have a great life, and you will too. And that helps them at that moment. And then stage 2, life is limited, where we get frozen. We're grieving our past life. I have a friend going through smoking cessation, and she's grieving a lot of the rituals that were around her smoking cigarettes. And she's very frozen and stuck right now. We have a lot of people in our systems who are frozen and stuck. And I always say, if that's the case, we haven't done a great job in listening and finding from that what they can care about and where they want to go to. Often in our systems, we focus on stage 1 and stage 2, where we need to go through the rest of these stages. And activation is the key to doing that, but activation based on where people are right now. I don't have enough time to tell you this story of my little dog Cassie right there, so we're going to go on to the next one. Next slide, please. Hello? Next slide. Great. Another framework as you think about activation is levels of patient activation. Again, this comes out of the work of Judith Hibbard, and you can see her research at the top. It's currently owned by Insignia Health, and you should explore that a little bit. They have a patient activation measure, and they say people really go into 4 stages. And here they are at level 1 where they're starting to take a role, and they go through stepwise, and there are things you can do to help them. But what's important here is often we put together an activation program that really works for people in level 3, but we're trying to help people in level 1. You've got to go through level 1, level 2, and level 3 before people are going to jump in and do our nice canned program. That doesn't mean the program isn't good. You just have to be aware of where people are. Next slide, please. I'm hearing some background noise, so if you're not on mute, that'd be great. So then we have a motivational interviewing. If you haven't done, any of this reading, it'd be great for you to look at what Miller and Rolnick have said, but they're also saying that people are not motivated for change at the same time in the same way. So part of what we need to do is engage people, invoke their perspective, listen, find out what they care about, broaden that perspective, and build momentum for the change. And you do that, again, based on what they care about. And then we can move forward and put all these great tools and resources in people's hands. Next slide, please. So another a way that we do that at Optum is through our peer coaching programs. I'm not going to talk about this too much because the NYAPRA folks, Harvey and Tanya, are the best in the country in this, and they'll talk about that some. I would say to you, if you look at that gray box, the first dot, in Harvey and Tanya's programs, we've seen a 47.9% decrease in the number of people who are using outpatient services after they get this activation coach. And I will tell you that I have, Mary's story up here. That's not Mary's picture, and Mary is not her real name. But in using an activation approach with Mary, she's an individual that for 5 years, the best she could do was 2 nights in a row at home. Otherwise, she was in the hospital all the time for 5 years. In giving her a peer coach focusing on activation, she's now been home for 6 months after 5 years of 1 night at a time. And while we care most about that person, I would also point out that just 6 months of this service has saved over $122,000 in spend. Next slide, please. So how do you do this? Especially with a hard-to-work-with member like perhaps Mary was. You listen carefully, you respond. You elicit the member's own motivation. You align the member's own motivation to the treatment plan. So you're not talking about their symptoms. You're talking about working at Pizza Hut and how the symptoms get in the way of achieving that. It's helping people prepare for the doc so that time is used very wisely. And it's identifying where the member is in the stage of recovery and the level of activation and curating that selection of self-care tools. Next slide, please. I have some pictures of self-care tools on here. So another way of saying the same thing. You're identifying members' their strengths, where they're strong, not where they're bad and wrong and sick. You're going to build on those strengths. You're helping them create their own personal goals that have nothing to do with their symptoms, but where do you want to go? You're linking that in to the treatment plan. You're providing meaningful education. We have very little time with you. And the docs and all of that, so don't just depend on us understanding you with 15 minutes of time. Give us stuff we can look at when we're not so overwhelmed. Help us access community resources, including support. There are great online, free, and face-to-face support groups. Help us identify our own triggers, maybe using RAP. You see a picture of RAP up there. There are smartphone apps. There's Mary Ellen Copeland's RAP book that you can purchase. There's the free SAMHSA tool. There's a link to it. Help people look at their whole health. Next slide. So I've given you a couple links to activation tools that are specific to Optum. They have the Optum name on it. They are on the outside of our Live and Work Well site, so they're free to the public. You can link in and use them as you wish. I've also attached to this presentation a couple of different tools. They are a bunch of great tools that are out there for addiction recovery and for mental health. You can download them, and there's a couple of PDFs that you can download as well that give you a whole series of activation and self-care tools that you can be using. They're completely free of charge. Next slide, please. So, to summarize, yeah, I get it. We're all too busy. Everybody has too much to do. And adding this kind of intentionality around activation is extremely hard. But it's at the core of what we're doing, what we need to do. Otherwise, we're cycling people in between the first stage of change and the second. They're going from being ill to being overwhelmed to being ill, overwhelmed, ill, overwhelmed, and they're never moving to stage 5. And really, it's a core of the way medicine is going, this self-care and activation. And you see a nice quote up there. Next slide, please. When I was at DBSA, I did a very large survey of 2,000 people, and I asked them a bunch of questions, one of which was, I want the healthcare system to do. This was not the answer I expected, but when the analysts came up and looked at all the responses of these 2,000 people, here's what people want from you and me. They want hope. So if you're doing nothing else, please give people hope. Thank you so much. I am now thrilled to be able to pass this on to Harvey and Tanya. They are the best of the best in the country. So without further ado, let me turn this over to the great Harvey Rosenthal, the CEO of the New York Association of Psychosocial Rehabilitation Services. Thanks, Harvey.
Thank you, Sue. Hi, everybody. Next slide, please. So just a background, NYAPRA is the New York Association of Psychiatric Rehabilitation Services. We're a peer-led state and national change agent in the sense that we're really looking to improve services and social conditions and policies for people with psychiatric disabilities. Our focus is on promoting recovery, rehabilitation, rights, and community inclusion. I'm a person in recovery myself, 46 years. I've also worked in the field for 40 years as a provider and as an advocate. And on our staff here, NYAPRA is very much about peers. We have a majority of peers on our board and on our staff. Next slide, please. So I'm going to be talking about challenges and barriers. I just want to say that the model I'll be talking about was created in 1994 by NYAPRA, and it worked originally out of state hospitals. And what I'm going to be talking about today is not a model where people are easy to find and need to be energized. I'm going to talk about a model where people need to be found and grounded and brought out of the fire, so to speak. So next slide, please. Okay, so our state hospital peer bridger program, we switched over. In 2008, we began doing some work with Optum on the precursor of a health home. And I want to focus on it for a second because the environment we're in now, whether it's the ACA or healthcare reform, Medicaid redesign, the development of health homes or DSRIP if you have that, the mantra is always the same. How do you keep people out of hospitals and emergency rooms? And so that's a real focus for a lot of our programs and projects. The people that we were working, though, in these, the precursor of the health home and now the peer bridger program are by definition, and I hate to hear terms like high cost, high needs, hard to serve, super utilizers. I think it's really important to get away from those terms. But these are folks that really have not responded. And a lot of the time, they're blamed for that. Excuse me. But we need to really understand what they're dealing with. As Sue says, we've got to start with the person and really look sort of deeply into why they're not doing what we want them to do, which is stay at a hospital and take your medicine and show up at appointments. It's not high on their list at the moment we're trying to engage them. People are dealing with trauma, unstable housing, so they're hard to find, homelessness. Certainly not working and poor. So people may run out of money early in the month and they're left really sort of wandering. There's addiction. People are isolated. They're idle. They lack hope. And their lives are frequently, because they're up against it, because of their disorganization, their sense of crisis, the addiction, they really are not, responding to us is not high on their list. And particularly if we come there with an agenda, and Sue said many, many times, it's really important to come to people to find out what their agenda is and not to basically have to listen for 8 seconds because what you want to get to is sign this form, come to the program site, and take your medicine. Because I have an agenda, I'm told to keep you out of hospital and get you on medication. That may be what happens, but it's not a place to start. And I just want to say one other thing about readiness. Very often, a lot of the time, we're meeting with people as they're just leaving the hospital, but back into the community in a state of crisis. And crisis is one of the most powerful precursors for readiness. So that's really important. One last thing on a barrier is culture. There are a number of cultures that really view mental illnesses or mental health conditions as a matter of shame or denial, and so we haven't been able to work with some families because their families wouldn't allow it. Next slide, please. Next slide. Thank you. So we developed a model, really Tanya developed a model, and she'll tell you about it, that really begins with outreach and engagement. And I want to just say one thing about that. Outreach and engagement takes time. You'll hear, in some cases we had to go 78 times, many times to find and engage people again and again. Relentlessness is critical and out of real concern for the person. And so one quick thing I want to say on the side is that the reimbursement models normally don't pay for outreach and engagement, even though the return on investment is well beyond that, and Sue gave you an example. But very often as outreach people, you're expected to find and engage people quickly. There's not reimbursement for taking longer. They want you to bring the person in to see the doctor. Those are the wrong kinds of pressures. So outreach engagement is critical. Very often, again, as I said earlier, the motivation for change is often crisis. People are leaving hospital. They're poor. They're hungry. They're in a state of domestic violence or trouble with families. So it's not a place to start talking about wellness and making a wellness plan. It's about talking about crisis and a relapse prevention and crisis plan. Then when people are, for lack of a better word, more stable and more able to look beyond the next hour and day, we can start talking about RAP or WAM or self-management. And when we first came on the scene in New York, they were talking about illness self-management. I think it's really important to talk about wellness self-management. It's more positive, and it is about affirmative action to managing your own health. And then the final stage, from outreach, engagement, crisis stabilization, wellness, to connecting people to services and supports. Next slide, please. I'm just mindful of the time. So evidence-based outreach and engagement. And the reason I say evidence is that Sue showed you the evidence and the success we've had with Optum. And so that's really important, and I think we have the data. So again, this is really about relationship. This is really the key to our work. If we're not good at relationship, then I don't know how we were able to be successful. And a lot of that is listening, is empathy, is being, in a case of peers, an example of hope, and meeting people where they are. And that means very often, in the case of the projects we have, finding people in their communities. These are not folks who are going to come to the office, and it's important for us not to view them as so-called non-compliant and label them in that way. The responsibility is on us to keep going and finding out where the engagement is, and responding to their most immediate needs, which again may be emergency housing or food. In those areas, it's not a place to start a relationship saying, I need you to come see the doctor and take your medicine. Again, you may get to that, but a long-lasting relationship starts with where the person is. And again, as I said, relentlessness. You can't work enough to find people and then to keep coming back and engaging them. And again, we talked about linkage to supports before. Next slide. So again, we're working on a harm reduction model, as I said earlier. We're really trying to address the most immediate needs. This is not about symptom management, as Sue mentioned at the beginning. It's about putting out the fire and making that relationship. In our projects, we're lucky to have wraparound funding, which allows us to put people up in emergency housing or buy food or pay for transportation or whatever's necessary, whatever it takes. And it's important for us to be available off hours because we stand between people in the emergency room in the hospital. And to do that, we really need to be available. And very often, we wind up being the person that people call when there is that crisis. Next slide, please. So I'm going to turn this over to Tanya, and this is a very powerful story that really, I think, really points out empowerment and recovery in action. Tanya?
Thank you, Harvey. Good afternoon, everyone. I'm going to tell just sort of a brief story about an individual that we worked with in the very beginning of our project with Optum. And it was an individual who had spent a number of years struggling with chronic physical health conditions. He had both renal failure at the time that we engaged with him. He was also had different heart conditions, struggled with active substance abuse, in and out of detox multiple times a year, was basically sort of living between the streets and his mother's apartment in New York City. And one of our bridgers went to the house to engage him, had to go back probably 6 to 8 times to be able to actually catch him at home and really even get to speak to him. Didn't want to engage at first, but kept following up. Engaged the family, mostly not in his treatment, but in trying to get him engaged into the program. And after so many times of coming back, the individual said, you keep coming back, maybe I should talk to you about this. We were able to get him into a longer-term rehab, got him engaged with a care manager that was able to work with him on his sort of chronic health conditions. We introduced him to 12-step, and in the beginning we're actually taking him to the 12-step meetings on a daily basis until he was able and interested to go on his own. Also got him engaged in outpatient treatment. And so this is just some cost information that was actually provided to us for this individual. So in 2009, prior to enrollment, he had 7 detox days at 4 different facilities for a total of over $52,000 behavioral health Medicaid dollars. In 2010, there was 1 detox and 1 rehab referred. This is after us working with him, and this was actually something, we helped him to get into that rehab for a brief relapse. $20,000 spent, and then was abstinent for an entire year. So that just shows you that with the right sort of activation and engagement, what people can do and what the outcomes can be for people. Next slide. So what are some of the program supports that that promote activation and self-management? The biggest program support can be, is it a recovery-centered approach that you're taking? Do you believe, or do you expect even, that recovery is going to be the outcome? It can't be the exception, it should be the expectation for all people that you work with. And if that's the focus of the organization, and that's the mission of the organization, I think that support is going to lead to a higher rate of engagement and activation. I think also, as Harvey said, engagement, although different than activation, and good engagement and recovery-focused engagement is the key to lead to activation. I mean, going to where people are, meeting people where they're at, and really spending the time and resources to look for people and engage them in a meaningful relationship is going to increase the likelihood that you're able to get people to activate in programs as well. Next slide, because I think we're going to discuss this a little more as well. So some key skills, and Sue ran through a bunch of different key skills, and I just want to add a couple of other things in skills. I think an important skill, and this also goes back to a program support, is you can't just talk the talk. You have to walk that talk as well. So the expectation can't be that people are activated in their own self-management if your staff and your organization doesn't have the same expectation of the individuals who are working with people. You really need to mentor and model what the expectation is for the people that you're going to work with. So sort of looking and seeing, are you an organization that has a wellness culture? Are you an organization that promotes wellness? What do you do for your employees and the individuals that are coming in contact with various members to support that same, activation and wellness management that you're expecting of the people that you're going to serve? People also need to be empowered. Most people feel that doctors are more of an authority on your own health, and when you go to a doctor, the doctor's word is final. People need to be empowered to engage in a relationship, a cooperative relationship, as Sue had said, with their providers, with their treatment teams, so that people feel that they have as much a role, if not more of a role, in what's happening with them and what's going to be set up with them than doctors or providers might have. It's also good to train people on health literacy. I mean, it would be impossible for us to be able to train the bridgers who work with individuals on every possible physical health condition. But oftentimes, there's an example of the high rates of diabetes for individuals with psychiatric disabilities. It's one thing to tell somebody they have diabetes. It's another thing to work with them on how to control diabetes. There's shocking numbers of people that may not know what the relation between what you consume is to what happens to your diabetes. And it seems as though people would, but when you're not activated in your care, or it's sort of been taken care of for you, that knowledge may not be there. So being able to support people to get the information they need about the different conditions they struggle with, and empowering them to be able to then do something about it. Next slide, please. I think it's also important in programs that you hire the right staff. So staff that are engaging, staff, again, that are people who are activated and know how to be activated in their own healthcare. Staff that are interested in working in these sort of intense relationships with individuals. People need to be trained and retrained. This is there's always going to be something new or something different or a different approach, and so training should be a key part of what you're doing with staff. I talked about incorporating the recovery-based engagement model. And again, the activation is the expectation for everyone that comes through the door, and how can you make that happen? And most importantly, that your staff and your organization and the entire way that things are operated are really moving towards everyone having a fully activated sort of management of their own health care. And I think that's the last slide.
I just want to make one other point, and it's a personal one. I think I would like a bridger when I go to my doctor, and because I have two problems when I'm there. Number one, I ask questions, but I don't listen to the answers. So it's not just that he's not hearing me. I either feel like I'm not understanding, or I feel like I should be, and I don't want to be a bother. I feel pretty brave in my advocacy role. I'm afraid of my doctor. I feel like he's in a rush, and I don't want to bug him too much, and I don't want to be a complainer. So can you see how all those things will stop me from getting the most out of when they finally do get me into the doctor, for example? And that's where, again, a bridger's help in preparing and supporting people is really important.
Thanks, Harvey. So just in reviewing the main questions, if either of the three presenters want to address. The first one was, what barriers and challenges should providers expect when activating self-management? How do you overcome those barriers? What are program supports that promote activation of self-management, and how did you gain those? And then the third one was, what are the key skills needed to activate self-management, and how do you grow those skills? Any of the three of you want to add anything to those questions?
I do want to talk about program supports that promote activation if I understand it, and that is, for me, training is really important for our staff, and they're multiply trained. Tanya has our extensive peer bridger training. We get training in intentional peer support, in recovery coaching, in RAP, Wellness Recovery Action Plans. We're familiar with Larry's work, for example. So I think that training is a really important support to get staff really set up to do the right kind of activation.
And this is Sue. I think that Tanya talked really effectively about barriers. I also think that we just have to be intentional. We have to be intentional about baking this into what we're doing and not have it be something that's done off the corner of the desk. So that's one of the barriers. How do we design this into our systems? And if I can be so bold to say some more on key skills, I think that all of us, I talked about listening a little bit. I don't know anybody who doesn't struggle with that. And we are in systems we are rushing around. So how do we take a breath and really listen, both the consumers or patients who are listening to the docs, but also those of you who are doing whatever kind of care, if it's care coordination or, you're the educator, or, don't just throw things at me. Take the time to listen. There's another key statistic that I just want to throw out, and that is that, I gave you the 8 to 11 seconds that folks will talk, will allow folks to talk before being interrupted. But if we're allowed as patients to talk for whatever amount of time that we want to, on average, we'll just talk for 2 minutes. That's it. You can give us 2 minutes. So there is a fear that we'll go on and on and on and on. But really, pretty much we mostly don't. About 2 minutes is what we'll do. So give us some time to listen.
And just again, I said this before, but very often we're sent out with an agenda. Find that person, engage them. We had a managed care plan that said, we just need you to form a peer relationship for 7 days because we have to meet a HEDIS measure of they have to see someone within 7 days in order for us to meet our managed care standards. And again, it's harder to listen when you're feeling like there's another person behind you saying, let's go, hurry up, bring them in, I have to meet that standard, how are we going to get them on their medication? I can't say that enough. You really need an environment. I think environments that are successful are ones that really appreciate and reimburse for the amount of time it takes to really start where somebody is.
Okay.
Could I just pile one more thing on, and that is that, activation, as you saw from Hibbard, the first thing on the list was self-care. So as professionals, everybody should have an awareness of what's out there and be able, again, to say, okay, I know this and this that are completely free, and this would work best for this person at this moment. So part of what we all should be doing is becoming aware of what's out there that we can, put in people's hands. Thanks, Larry.
Good. Any other comments? Okay, I think we have experienced firsthand why these three presenters are innovators and leaders in the field. And I think we can open it up now. Rose, do we have any questions that have come in?
Yes, we have several questions that have come in. The first is, how do you get to build relationships with a member who constantly avoids and refuses engagement?
I'm sorry, Larry. Yeah, this is Tanya. Sorry, Larry. By avoiding engagement, I'm going to assume that you're doing outreach to them and they're not responding in any sort of way. And so I'll just address that in a couple of ways. And I think it depends on maybe how you're outreaching the person and who might be outreaching the person. And so there may be strategies to send someone else. I mean, are you able to send a peer to outreach the person as opposed to provider? If it is a peer that you're sending to outreach the person, are you doing it in person or over the phone? And really the relentlessness that Harvey talked about. And I'd say if you've outreached them and they are receptive and they're just not showing up, then maybe you need to try to engage them in something different. And what I say by that is, if you're trying to engage them, let's say in substance abuse of some kind, but they're not interested in being in recovery, maybe the engagement approach needs to be some other focus, what they are going to engage in or what they are interested in, and it can lead to overall wellness once you've built that relationship with the person.
Excuse me, I once got asked by a big provider in New York City, and they said to me, "You're a rights guy, so when we offer things to people and they don't want them, shouldn't we respect their rights?" And I said, well, the person needs to have informed choice. So if you sent the same staff person out and offered the same thing, send somebody else out and offer something different. I think it's important to really, I think Tanya was talking about offering something different, but it also may not be the match with the staff person, and that's okay, but then you have to make the right choice there.
And I would just add to that, I would look at how you're approaching that person, and if you're sitting down and saying, all right, Mary, we would love you to do this. Well, Mary doesn't have any sense that you know who she is or what she cares about, and you haven't approached it that way. Now, Mary, tell me a little bit about do you have grandkids? Do you have pets? What do you love? Tell me about yourself, Mary. Tell me more about, what really matters to you. And then you can say, I bet one of the things, from what I'm hearing you say, it sounds like what's really important to you is to be able to play with your grandkids, or that you're able to get out there and see new people or whatever it is that they're kind of giving you a clue about, and then you frame, some idea to say, wouldn't it be great if we could find some simple things that would help you achieve that a little bit more? So that's not saying, hey, I've got a program for you and I want you to do this. It's saying, I've heard you tell me who you are and what I think you want, and let's see if there's some match here. And that's a much different approach than I think the way we usually go forth. Thanks.
Great, thank you all. Our next question is, when a person with bipolar disorder is in a manic state, it is very difficult to get them to seek treatment. What has worked for you all in your experience?
Well, you know what? I have some of that myself. So, I'm aware that people are thinking, talking, saying, doing too much. So I think I try to get, and it's always easy for me to be still again and to lower things down and to just try to bring down the energy and the talk and attention. There's no magic bullet here, but I think if you're talking about somebody who's really sped up, I think it's got to be a way to get their attention and to also provide a grounding. But I think all the other rules apply regardless of diagnosis that we've talked about today. Really listening, paying attention, and providing the most immediate thing that they need, they want.
And Tanya, go ahead.
Oh, I'm sorry. I would say that the time for activation and engagement isn't once the individual is at their worst and in need of some sort of more intense treatment. So this model is really more of a prevention model than a crisis intervention model. If a person's, activation is something that should be introduced prior to. I mean, if this is a sort of cycle that this individual goes through, then there'd be a plan around activation and what they'd like to see in place that might include a wrap or something, when you're at your worst, what would you like to see happen? That's sort of planning around it. That would be a fully activated person, that there's a plan in place as to what that person would like to see happen once they get into that state.
And to Tanya's point, what you're really asking is how do I engage that person in treatment, not how do I activate them in self-care. And engaging people in treatment is tricky. But again, it can be, you're going to do a little bit better if you're thinking about people's individual motivation. I've heard a great deal of success when folks talk about, again, this behavior is not helping you achieve what you want to. And it's causing this amount of trouble for you in your life, and let's talk about what you want to achieve and how we can get there together as one of the keys in people getting engaged in care. And then I do agree that this is prevention in a way, but it's really also moving to wellness. But it's not necessarily, activation is not necessarily going to take the place of engagement. So you got to people get engaged, and then you help them activate in self-care to move to wellness and to prevent further and future trouble.
Great, thank you. The next question is, how do you get the organization to give some special attention to the person who is doing the outreach and engagement process? What would be a reasonable incentive for an employer to provide for self-care?
I'm sorry, I don't understand the question.
Sorry.
Is it something about how do I incent self-care among someone doing outreach? Is it how do we persuade an employer to take outreach? So I would just say that how do you persuade an employer to do this work? Well, there's a lot of data that I've shared with you, and I have more about the fact that you have better outcomes, and that is important for all of us because it's the work that we do, but it's also important in the ACA and kind of the way that things are moving in new healthcare. How do you get a provider or a provider system or a system of care to, really honor that individuals who are doing this kind of outreach need their own self-care? I think that that's a matter of adjusting culture within a company, and I'm happy to talk about that, but that's like hours and hours of conversation about how you change culture. But in a short, people want to walk the talk, right? That's how I'd approach HR on that issue.
Great, thank you. If your main way to help in outreaching to patients and clients is telephonic, what advice can either of you give to reaching them and keeping them engaged in their care and conversation? I
don't see that telephonic is that much different. We do have best when we can actually go and be face-to-face, absolutely, no question, but you're still using a lot of the same skills when you do telephonic. Wouldn't you agree, Harvey and Tanya?
Yes. Well, Tanya, you want to talk about it? Because we do both telephonic and speed-based, right?
Yeah, so I think that the best engagement is always in person, but I do think it can be harder sometimes to only be able to do it telephonically, but I do think it is some of the same skills, as Sue had said. I think, the same relentlessness. I mean, you have to sort of keep calling, try calling at different times. It's hard when you only are calling between the hours of 9 and 5, if that's sort of a schedule limit that you might have, because if people are at work, you might not be catching them. So try varied hours that you're trying to contact somebody as well. And it's still around engaging them around what they want to be engaged around. So, to call and try to engage them or force them to participate in a program they may not be interested in, as opposed to having conversations, real conversations about things they want to talk about. So it is a lot of the same skills. It can just be a little more difficult to do it if you're limited to telephonic.
And if I could just add, I don't know how many of you out there ever took a marketing class in college or whatever, but remember that old saying, 7 to 11 times. I have to see a message 7 to 11 times before I take action, right? McDonald's gives us commercials all the time that just, kind of remind us that they're out there, so we'll go and get a burger. Why are we expecting consumers to respond each and every time that we call and do, give patients the same amount of time that anybody else has to make a change or to select? 7 to 11 times for an outreach is frustrating, and we'd like to just make one call and be done. But that's just not how the world works in any way, not just within integrated care, but anywhere. So be patient with yourself and be patient with us.
Sue, I wonder, I was just thinking about telephonic activation or support. Maybe I'm asking you, Optum does a lot with apps and the use of phones. Would that be something to talk about here for a little bit?
Well, absolutely. And again, remember, sometimes we have to outreach by phone because that's what we have to do. That's what the contract is. The members are not nearby. But sometimes we're going to want to do that because that's how people respond best. Sometimes people respond best with an app or with a text or with a face-to-face visit, and maybe they don't want it at their home, they want it at the local Starbucks or the local McDonald's, speaking of McDonald's. So again, we ought to meet people where they are. And also when you're talking telephonic, you also have to adjust your conversation based on the needs of that individual and not expect that your script is going to work. They need to be able to trust you. And it doesn't matter if I'm living with diabetes or if I'm living with a mental health condition, I'm not going to have that immediate trust with you. So there has to be enough time and interchange with your phone conversation so that they know a little of you, you know a little of them, you know a little more about their life. It's not necessarily the way we set these things up. And I have to say that's how you do that. Speaking of smartphone apps, since you gave me that option to talk about, we do see that people, the data shows us that people in the public sector, as well as people who get their coverage from their employer, we all use smartphones pretty much at the same level, right? So we often thought, we can't use smartphones with people who are being served by Medicare or Medicaid, but that's not the case. So you need to think about adding that to the mix of what you're doing. Thanks, Harvey.
You're welcome. I mean, I know there are apps that remind you to eat and, breathe, meditation apps. There's all kinds of things that help you remind you to do better self-management. I just wanted to point that out.
Thank you. So the last question we have time for today is, I am aware that engagement and outreach takes time. This can be challenging when working for a program that limits the amount of time for this to happen, causing these clients to somewhat get lost. Any suggestions on this?
Well, if you're talking about reimbursement, I almost, Sue, if you don't mind. See, in New York, we have a health home project, and they're What the outreach rate is $137 a month, and you only get 3 months. That's just ludicrous. But so you're a payer. How do you structure it so that people are actually encouraged to spend the time and more time?
Well, Harvey.
Spot. Yeah.
So the relationship that we have with many people is, paying, all of us are in the age of looking at outcomes-based reimbursement, right? Or, bundling a service so that we're not just paying for one people, we're paying for a bundled set of services. And that allows you to kind of say, okay, part of this is outreach, part of this is face-to-face time, part of this is other. So those are a couple strategies to move forward. I think we're in a moment in time with the ACA where people are trying a lot of different things, and there's a real interest among many managed care companies to find different ways of thinking about this to get to those outcomes that we're all seeking. But let me just back up a little bit and say, when you're dealing with a program that says, all right, you got 10 minutes with this person, or the buzzers are going to buzz, or, whatever, they're on to the next thing, start thinking about how you're going to use that 10 minutes, and start thinking about using 2 or 3 minutes with a, more, how are you, or tell me a little bit more about you, or some of those relationship building things. Use 1 or 2 moments. Think in advance about that person, and use 1 or 2 moments to talk about, have you thought about using, this 1 or 2 different self-care techniques? And I'd love to talk about that with you when you come back. Think about, sneaking that stuff in different places, and then think about going to the system, whatever that is, if that's your supervisor or if it's a system of care, and saying, so we've set this up in a great way that gives us 10 minutes, and I get why, but I also know as a company we want these improved outcomes, and look at what the data is showing us. I wonder if we invest a little bit more time, like go from 10 minutes to 15, we might be able to really show much better outcomes, which also means that our cost of care will adjust down, and some of those things baked into the ACA we're going to be able to meet and or not get penalized by. So, I would be strategic about moving that in the system through your boss or through another way to say, give us a little bit more time, and we're going to be able to have better outcomes that really have all these benefits to our system.
Great, thank you, Sue. So that is all the time we have today. Once again, the recording and transcription of this webinar will be available on the CIHS website. We encourage everyone to, once they exit the webinar, to complete a short survey, and please be sure to offer your feedback on today's webinar to inform the development of future CIHS webinars. I want to extend a thank you to all of our presenters for joining us today, and thank you to all of you for joining our webinar. And please stay tuned for more webinars in the near future. Have a great afternoon, everyone.
Bye-bye.
Thanks.
Thank you.